Well, good evening, everybody. I'm Dr. David Anderson. I'm going to be doing the patient information seminar this evening. I'd like to welcome everybody. The plan is to go through the PowerPoint presentation for the next 30 minutes or so, and then we'll have a question and answer session. If something is pertinent to the slide that I have up and you feel like raising your hand, go right ahead. This is informal. And we'll go ahead and answer the question then. If it's something that can wait, we can always go back to that particular slide. Should take about an hour, and then I'm going to have Jessica Allen, our quality coordinator, come up and speak to you about insurance and billing issues, and Carla Glover's in the back as well. She can help answer questions also. This is our St. Francis Surgical Weight Loss Center staff. I'm Dr. Anderson, my partner's Dr. Chaudhary. All these lovely ladies here work for us. They do a superb job. We've been operating since March 23rd of 2009. To date, we've done 228 bariatric or weight loss procedures, and we've had outstanding results thus far. Our coordinator is Ms. Carla Glover. We have a registered dietitian, Leslie Barankin. She works with us 3/4 of the time. We have a psychologist who does not work for the hospital, as the rest of us do, but she has her own practice and specializes in eating disorders. Jessica Allen is our insurance coordinator and surgery scheduler, and then the rest of the ladies work in the office with us. What we're going to be going through today is what is obesity. Hopefully we'll give you a definition of that. We'll discuss the daily challenges in people's lives, the cost of obesity, the conditions associated with obesity, and then go through the various surgical options. As of right now, the 3 surgical options are the adjustable gastric band, the sleeve gastrectomy, and the old standard, the gastric bypass procedure. And then we'll go through a summary. Jessica will take you through the information packet which you have in front of you and answer any of your insurance questions. So what is obesity? Well, the definition is it's a disease of excess fat storage with a number of associated diseases, something that we call comorbidities. And I'm going to be going through all the associated comorbidities in just a few minutes. Part of obesity is related to genetics. That's a component that you can't control. Part of it is behavioral, and part of it is environmental. So whatever environment you put yourself in and your behaviors also affect your ability to become obese. We have several definitions. Morbid obesity is defined as 100 pounds over your ideal body weight or a body mass index of greater than 40. A body mass index of 35 with one or more severe comorbid conditions puts you in that category in order to have surgery. And the Food and Drug Administration recently approved the Lap-Band, which is one of the 2 adjustable gastric band devices for patients who have a BMI of greater than 30. It's approved by the FDA, but most of the insurance companies haven't approved that yet. And here are the various categories. Normal weight is considered a BMI of 18.5 to 25. Overweight is 25 to 30. Obese or class 1 obesity is 30 to 35. Severe obesity is 35 to 40. Morbid obesity is 40 to 50. And what we call supermorbid obesity is a BMI of greater than 50. If you look in your information packets, you'll see a small wheel. And I'm going to let Jessica go ahead and explain how to use that.
Most of you should have the wheel that's this 2-sided, and what you do is you find your height right here on the center wheel, and then you turn that to your weight to line up on the bigger wheel, and where that arrow points to, that is your BMI. So if anybody has any questions, we can talk about it afterwards, okay?
It's estimated that 65% of adults are either overweight or obese, so that means a BMI of greater than 30. And when you have a BMI of greater than 30, it's on average 30 pounds more than your ideal body weight. The morbid obesity is greater than 100 pounds over your ideal body weight, or a BMI of 40. 32, or almost 1/3 of all children are considered overweight. 4.8% of all adults are morbidly obese. We have about 310 million people in this country, and so we have between 15 and 16 million who are morbidly obese. The total medical costs back in 2003, 8 years ago, was $75 billion, and they estimated at that time that 325,000 people died from obesity-related deaths. Here's a map of the United States that show the trend towards obesity. If you look here in 1990, most of the states had less than 19% of the population were considered overweight. As I said earlier, it's 30 pounds or more over your ideal body weight. You can see just 9 years later, the trend is towards more states with between 20 and 24%. And then by 2008, we have a high number of states that have percentage of people close to 30%. South Carolina is the 5th heaviest state. Almost 31% of the population is considered overweight. And then here's the breakdown by counties. Here in Greenville, it's 26% of the population. If you go further south, particularly Orangeburg, Bamberg, Calhoun, almost 37% of the population is considered overweight. So just going through some of the obstacles and prejudices faced by people of size every day: turnstiles, movie seats, stairs, airplane seats. All of these things are daily obstacles. It's estimated that it can affect your life expectancy. In younger and middle-aged women, and an increased BMI may lead to premature death. And if you look at this graph here, it says teens entering adulthood with a BMI of greater than 40 will die 8 to 13 years earlier than the general population. And they've done 2 studies which show that. And what is the cost of obesity? Conventional diets have less than a 7% success rate at 1 year. If you look at their 5 and 10 years success rate, it's about 2 and 1%. So despite what you may see on the cover of People magazine every 3 months about people losing tremendous amounts of weight and diets, oftentimes they don't keep it off. There's the day-to-day living, clothing and food, higher cost due to size and amounts. Insurance goes up. It's estimated that if your BMI is over 35, costs are 44% higher than somebody with a BMI of less than 25. What are the conditions that are associated with obesity? I've divided this up into certain organ systems. The first one is the cardiovascular, which includes the heart and all the blood vessels. Some of the commonly associated conditions with obesity include angina, which is where the heart doesn't get enough oxygen through the blood system, leads to chest pain. If the chest pain and the lack of oxygen is severe enough, it could lead to a heart attack or myocardial infarction. Congestive heart failure is where the heart can't pump the blood fast enough out of the lungs. The fluid can pool in the small air sacs and lead to congestive heart failure. Hypertension, this is probably the most common medical condition that we see associated with people who are morbidly obese. 85% of the people that we see who consider surgery have some degree of hypertension. Hyperlipidemia, which is high cholesterol or high triglycerides, is seen in about 35 to 40% of our population. Deep vein thrombosis, that's where blood clots can form in the lower extremities or in the pelvic veins. If they break off and migrate to your lungs, they can produce a pulmonary emboli. It's estimated that pulmonary emboli kill 200,000 people each year here in the United States. As far as the respiratory system, there's a disease called obstructive sleep apnea, or OSA. It's an extremely underdiagnosed problem. I would say almost 50% of the people come into for consideration of weight loss surgery have some degree of obstructive sleep apnea. If you find yourself snoring loudly at night, if you have restless sleep, wake yourself up frequently, wake up the next morning, don't feel well rested, have an early morning headache, or if you find yourself dozing off the next day or afternoon because of poor sleep, those are 5 of the 9 symptoms of sleep apnea. Obesity hypoventilation syndrome, when patients come into the office, I will usually ask whether they're able to walk up a flight of stairs. If they're they get short of breath up a flight of stairs or walking down a long hallway. That's because too much weight either impinging on their diaphragm or just because of the simple exertion of doing those tasks. Asthma is much more common in people who are morbidly obese. And complications with general anesthesia. I still do a lot of general surgery in addition to weight loss surgery, and we see people who have a hard time being intubated or having the breathing tube taken out after relatively simple surgeries just due to their size. In terms of the gastrointestinal system, gastroesophageal reflux disease or reflux is a common condition. Oftentimes there's so much intra-abdominal pressure because of weight that it will lead to a hiatal hernia, where actually part of the stomach herniates up into the chest cavity through what we call the hiatus in the diaphragm. That can lead to reflux or heartburn. NASH, which is non-alcoholic steatohepatitis, where fat is deposited in the liver. Long-term fat deposition into the liver can lead to cirrhosis and liver failure. Cholelithiasis or gallstones, quite common, and hernias. Hernia is basically a hole where one shouldn't be. They can occur in the groin area, which are inguinal hernias, at the belly button, which is an umbilical hernia, at the hiatus, where the esophagus goes through the diaphragm, that's called a hiatal hernia. Or if you've had previous abdominal surgery and had an incision, then you can get an incisional hernia. And those are all weak spots in the abdominal cavity. And because of the increase in the size of the abdominal organs or increased amount of fat in the abdomen, they put more pressure and lead to a greater degree of hernias. Diabetes mellitus, we see this in anywhere from 40 to 50% of our patients who consider surgery. Polycystic ovarian syndrome is seen in a high percentage of female patients, and essentially fat that is deposited in the periphery of your body, such as in your triceps, your breasts, your buttocks, your hips, that fat can break down, and one of the byproducts of that fat breakdown is estrogen, which can lead to cysts on the ovaries. It can lead to menstrual disorders. Many of our obese female patients haven't had a menstrual cycle in a number of years, and that's one of the reasons. Infertility, it can make having a child difficult. And then if you do get pregnant, complications with pregnancies can occur, such as gestational diabetes or gestational hypertension. And there's even an increased risk for birth defects in mothers who are morbidly obese. In terms of the musculoskeletal system, gout, which is uric acid deposition, is more common. Immobility and osteoarthritis, these two go hand in hand. Any of the weight-bearing joints, such as in the lower back, the hips, the knees, the ankles and the feet, can be affected. The joints are not meant to carry an extra 100 or 200 pounds. That can lead to destruction of the cartilage. It leads to pain, which can lead to immobility and the arthritis. Lower back pain and joint pain are all in that same family. There's an increased risk in cancer. They've done some interesting studies in England that showed that all of these types of cancers are more common, particularly the first 5 here: breast, colon, endometrial, cervical, and esophageal, but also kidney, liver, ovarian, and pancreatic. In terms of the psychological effects, depression in some form or another, either anxiety and depression or depression alone, is seen in about 90% of patients who consider weight loss surgery. Increased risk for suicide, increased risk of low self-esteem, and body dysmorphic disorder. In terms of the skin, it can lead to breakdown in even the skin, which is the largest organ in the body. Striae, which are stretch marks. Lymphedema, which is where the small lymph channels that channel fluid back to the blood system can get overwhelmed and lead to lymphedema. Cellulitis, which is one type of infection, and carbuncles, which is a different type of infection, are seen more in people who are morbidly obese. If you look at the comorbid conditions that I just went over, and then you look at the results after bariatric surgery, you can see that a lot of these conditions are either resolved completely or improved. Diabetes, 77% are resolved, 86% improved. Hypertension, 62% resolved, 79% improved. Sleep apnea and high cholesterol also. I'm just going to switch tracks and we're going to start going into the surgical aspects. I'm going to go through the anatomy. For those of you who aren't familiar with this, when you swallow something, you put it in your mouth, it goes through your posterior pharynx, and then it passes through a long hollow tube called your esophagus, which lies in the back of your chest or thoracic cavity. The esophagus passes through the diaphragm, it enters into your stomach. The stomach on average is 1 to 2 liters in size. It serves as a reservoir for food and liquid. It starts the digestive process, it churns things up, it's a big muscular sac. The fluid and food that sit in the stomach are passed through the pylorus, which is a valve at the end of the stomach, and that opens on average once every 20 seconds. Food and liquid then pass into your small intestine, which is where you get the absorption of the materials that you need to survive. You have anywhere from 15 to 20 feet of small intestine. Once things pass through that, whatever's not absorbed, you get some absorption of salts and water, but most of it is packaged in your large intestine or colon, and then periodically you eliminate that waste. So that's GI anatomy in 1 minute. So going through your surgical options, as I said earlier, there are basically 3. We have divided them into 2 categories. The first is restrictive. That limits or restricts how much you're able to take in at any one period of time. The 2 options are the adjustable gastric bands, and the second one is the sleeve gastrectomy. The sleeve gastrectomy is one of the newer procedures. I think it's quite exciting, and my opinion is in 5 to 10 years it'll be the procedure of choice. There's a combination which part restrictive and part malabsorptive. And the malabsorption occurs because we bypass a certain portion of the small intestine and don't allow the food and liquid to pass through there, and therefore it will not allow absorption. That's a second weight loss mechanism. The first procedure I'm going to go through is the adjustable gastric band, and we actually have a sample here. So what I'm going to do is just hold it up and try to briefly explain it. This is the band. I'm going to pass it around, let everybody hold it. It is a silastic ring with a balloon on the inside. The balloon is attached to this tubing, and then the tubing is attached to a port. The port lies underneath the skin on the muscle tissue of the anterior abdominal wall, and the band lies around in the area between the upper stomach and the lower stomach, just below where the esophagus and the stomach join together. And let me pass that around. The band, the best analogy I have is that it acts like the center portion of an hourglass. If you've seen an hourglass, you turn the hourglass over, the sand granules pass from top to bottom. What limits the rate of passage is the diameter of that middle portion. If it's wide, it's going to pass through quicker. If it's very narrow, it's going to pass through more slowly. And that's much like the band. The band, when you start filling the balloon up and narrow that segment, it's going to slow the passage of food and liquid from the top of the stomach to the bottom of the stomach. And what we do is periodically we will put a needle through your skin into this port and put saline solution and tighten that band. And what we call that is an adjustment. So we do these procedures laparoscopically. For those of you who aren't familiar with laparoscopic surgery, it's been the vogue or the main way of doing things since the late 1980s. We make small little incisions. We pass hollow tubes called trocars through the abdominal wall into the abdominal cavity. We pump up the abdomen with carbon dioxide gas. That lifts the abdominal wall away from the intestines and the abdominal organs, and we put a camera with a powerful light source in. We actually watch it on 2 TVs. That's all laparoscopic surgery. So the majority of these procedures are all done laparoscopically, which avoids a large incision. The large incisions can get infected. They can cause hernias. We're eliminating all those things. And obviously with smaller incisions, you're going to have less pain, and usually it's less time in the hospital. So all of our adjustable gastric band procedures have been done laparoscopically. It's the second most frequently performed bariatric procedure behind gastric bypass surgery. The national average excess weight loss at 1 year is 45.8%. Ours is slightly above that at 51.4%. It does require an implanted medical device, so this is a foreign material that's being put in your body. Some people don't want to have that done. It does require adjustments and fills, so you have to come back periodically and have that adjusted. Usually it's to add fluid. And people say, well, why would you need to add fluid? Well, the band is put in and it's shown nicely here in this diagram without any fat. But oftentimes there's fat that surrounds this entire area. So as you lose weight in the periphery, you're going to lose weight around the stomach, and that band will get loose as you lose the fat around the stomach. So periodically you have to go in and fill that up and make it more narrow. It has the lowest rate of complications, and we're not changing the anatomy at all. If someone wishes to have the band removed, we can go in a 15 or 20-minute surgical procedure, remove the band and the port, and we haven't changed your anatomy at all.
Is that for life?
It can be left in for life, and most people do choose to have that. If somebody wishes to have it removed, as I said, it's a 15 to 20-minute surgical procedure. But most of the time they leave it in. There are two bands. I put in the lap band by Allergan. You can look here on their website. The other band is the Realize band. They have some slightly different nuances. I was trained by the Allergan company back in 2003, so I have some loyalty to them. And Dr. Chaudhary was trained with the Realize band. Basically, it's the same results, or at least that's what we're seeing. I'm going to go through a case study. I always think that pictures can tell 1,000 stories, or however that goes. This is one of our first patients, actually our third patient. She was, at the time of surgery, she was 5'9", had a BMI of 39.1. She weighed 265 pounds. We went through her ideal body weight, and we found that the excess body weight that we calculated was 96 pounds. The medical problems she had were hyperlipidemia and gastroesophageal reflux disease. She wasn't on any medications. So we went ahead and did her surgery. And that's what she looks like 2 years after her lap band placement. Her BMI went from 39.1 down to 25.3. She lost 97% of her excess body weight. Out of the 96 pounds that we calculated that she was carrying, she lost 93 of them. The only medication she presently takes is a multivitamin. The reflux that she had prior to surgery is gone, and her hyperlipidemia or high cholesterol is gone as well. So what are the risks of banding? Well, you're putting in a foreign device, a piece of foreign material. You can get erosion of the band into the esophagus. The band can slip. The port can be displaced. You can get kinking of the tubing. The port can get disconnected. You can get leak of the band, port site infection, esophageal spasm. All of these things happen extremely rarely, but those are some of the things that can occur. What can you expect after the gastric banding? Well, we ask you to be on a strict diet, and we call it our protein-first diet. Your body doesn't need many carbohydrates, and it doesn't need much fat at all, except for a few essential fatty acids in order to have healthy function. So we ask that you take in protein as your first nutrient source. You need protein for healthy nerve and muscle function. And if everyone remembers, your heart is a muscle, so you want to protect those organs. The capacity of your food, of your ability to eat has changed. And we found that the most successful of our patients are the ones who adhere to the diet and say, I'm going to make certain lifestyle changes. I'm going to listen to what the program has to say, eat what I need to eat only small amounts, and combine that with some exercise and activity, and those are the people who are the most successful. You have to make the lifestyle changes. We do your first adjustment anywhere from 4 to 6 weeks after your surgery. So that's the band. The next procedure, this is the newest of the procedures. It was originally designed to be a pre-procedure for people who were in the super morbidly obese category, somebody who was 700, 800, 1,000 pounds, they thought they could do this procedure first, and then somebody would be ready to have a gastric bypass after losing 300 or 400 pounds. Well, the results were that this procedure was so successful, they didn't need to do the second procedure, the gastric bypass. This is the stomach, and how we do a sleeve gastrectomy, the anesthesiologist or nurse anesthetist will insert a rubber tube, which is solid, and we put it along what we call the lesser curvature, and then we choose a certain point beyond the pylorus, which is that little valve that goes from your stomach to your small intestine, and then we fire a stapling device. And when I first started doing surgery, we only had one row of staples, so it would be one row of staples on one side, one on the other, and you cut in between. And we had a lot of leaks and problems with it. Then they got to 2 rows of staples. The new staples that we use right now are 3 rows, and knock on wood, we haven't had any leaks or major problems with the stapling device. But what we're doing is we're creating a long hollow tube to go from your esophagus to your small intestine, and we're taking out about 80% of your stomach. That segment of stomach that we cut off is taken out of the body, and its blood supply is obviously cut off, not to be used. So we have changed your anatomy with this procedure. We've done all of our procedures laparoscopically. I think to this date we've done 41 of them. It's an option for carefully selected patients. The national average weight loss is 59% at 1 year. Ours is 56.3%. There's no implanted medical device like with a gastric band, but we are changing your anatomy and we're irretrievably removing something. This is one of our early sleeve gastrectomy patients. At the time of surgery, she was 5'3", had a body mass index of 46.5. The weight was 263 pounds. We calculated her excess body weight at 122 pounds after finding her ideal body weight was 141 pounds based on the Metropolitan Life charts. She had high blood pressure and low HDL levels. She wasn't on any medications. And then this is how she looked at 1 year after her sleeve gastrectomy. Her BMI went from 46 down to almost 26. Her excess body weight, she lost 95%. Of her excess body weight, her total weight loss was 116 pounds. The only medication she was taking after the procedure is a multivitamin. What are the risks of sleeve gastrectomy? These are the same for the sleeve, the gastric bypass, and the band. Just a different slide: abdominal hernia, chest pain, collapsed lung, gallstones, stretching of the stomach, vomiting and nausea. Then switching gears rather quickly, we're going to go discuss the gastric bypass procedure. The gastric bypass procedure is divided into 3 different procedures. The first is to create a small pouch which limits the amount of food a patient can eat. Then we divide the intestine and bring up a small portion of the small intestine to that pouch, and then we rearrange the intestines lower down so that the secretions from the stomach, the pancreas, and the liver can all join in and aid in digestion. This is called the gold standard. It's been done for over 40 years. It has the most published medical research to back it up. It's the one that's still done the most commonly, but it does have some problems. It has the highest rate of complications. Even though it's not a very high rate, it does have a higher rate of complications than the 2 previous procedures. So this is the way things look like at the end. So if you remember from the previous discussion, the first step in a gastric bypass is to make a small pouch out of the upper stomach. And when I say small, if you think of a 1 to 2 liter bottle of Coke, Pepsi, Mountain Dew, I'm taking that down to the size of an egg or a Dixie cup. So that's going to limit or restrict how much you're able to take in at any one point. And that's the main reason why you get weight loss. You just can't eat much. You eat 4 or 5 bites in a row and you're going to feel full. Beyond that, you're going to get some pressure and some pain here, and beyond that, it's going to come back up. The second part is I divide the small intestine down here. We bring it up behind the old stomach and the colon. This part of the stomach is removed in the sleeve gastrectomy. In the gastric bypass, it remains in place. It still produces hydrochloric acid, some other material that's needed in digestion, and so we do not remove it. We are bypassing this part of the small intestine, which is called the duodenum. It's very important in the absorption of calcium, some of the fat-soluble vitamins, and iron. So you have to take supplements. And then B12, there's something called the intrinsic factor, which is bound to food in here. And since we've bypassed this part, you also need to take vitamin B12. We do 95% of our gastric bypass procedures laparoscopically. It still is the most frequently performed bariatric procedure. The national average weight loss is 67%. So if you have 100 pounds of excess body weight, you can assume in 1 year you're going to lose 67 on average. Some people lose more, some people lose less. Depends on how adherent you are to our program and how much activity you perform after surgery. Our weight loss here with a gastric bypass is 71%. Unlike with an adjustable gastric band, we don't put in any foreign medical device. It does have a low rate of complications, but out of the three, it has the higher of the three rates. This is one of our gastric bypass patients. Before surgery, she was 5'4", weighed 333 pounds. We calculated her ideal body weight to be 145 pounds. She had 188 pounds of excess body weight. She had quite a few what we call comorbid conditions. She had diabetes, high blood pressure. She was only 32 years old, but she had a heart attack at age 30, and she had to have a stent placed in one of her coronary arteries. She had reflux, asthma, high cholesterol, and she had been a smoker, 1 to 2 packs a day for 12 years, but quit after her heart attack. And then she's on a long list of medications: Plavix, aspirin, Coreg, metformin, Protonix, Symbicort, all these medications she's on before surgery. And then this is what she looks like at 18 months after surgery. She went from a BMI, what was it before, 57, down to a BMI of 30. Out of those 188 pounds that we thought she had to lose, she lost 156 of them. That's 83% of her excess body weight. The only medication she's taken now are aspirin because she has that heart stent, Zantac, and a multivitamin. If anybody knows anything about blood work, cholesterol level before surgery was 201, which is high. Anything more than 200, you want to see that lower. Now the ideal is anywhere from 150 to 180. After surgery, 121, perfectly normal. Triglycerides, 226, very, very elevated. After surgery, cut in exact half, 113. Hemoglobin A1C, which is a long-term indication of how your blood sugars are under control. Normal is less than 6. Prior to surgery, hers was 7.3. After surgery, hers is in the normal range at 5.5. Her diabetes is gone. Her gastroesophageal reflux is gone. Asthma is gone. High cholesterol is gone. Hypertension gone. And her coronary artery disease, she doesn't need most of the medication she was on prior to surgery. Here's another gastric bypass patient. BMI was 50, almost 56. She was 326 pounds. She had diabetes, high blood pressure, reflux, joint pain, hyperlipidemia. She's on quite a few medications, most of them for very severe diabetes. This is what she looks like just 9 months after her bypass. So here's pre-surgery. There's post. BMI went from 56 to 34 in just 9 months. She lost 125 pounds. If her hemoglobin A1C, as I said, less than 6 is good. Anything above that is bad. was 9.5 prior to surgery. After surgery, it's 5.2. Blood pressure's normal, diabetes gone, reflux gone, hyperlipidemia gone, hypertension gone. And that's the lesson. People who either have medical conditions or will develop medical conditions because of weight, and you will, just takes time, they can be resolved and, if not markedly improved, with weight loss surgery. So after surgery, we have you on a liquid diet for 7 to 10 days after surgery with 2 protein shakes a day. Wherever you do surgery, whether it's a band, a bypass, or a sleeve, there's swelling, and that can narrow those openings down, so we just have you drink liquids. We put people on a 2-week pre-op diet where it's mainly liquids and protein, and we find people come in having lost 5 to 30 pounds, and that's a great way to start the weight loss process. The capacity of the food you can eat has changed. It's going to be markedly diminished. You can experience some discomfort and pain as your body heals. Length of time can return or can vary about return to normal activities. Usually by 3 weeks, I let people go back to the gym or do normal exercise. If they've had the procedure done laparoscopically, if it's done open with a larger incision, then it's usually a little bit longer. With the gastric bypass, there's something called the dumping syndrome, and what happens is that, as I explained earlier, when your normal anatomy have the stomach with the valve called your pylorus at the end, it slowly allows food to go directly into the small intestine, sort of when it's ready. In the gastric bypass, when we rearrange things, you're changing that. You're allowing high-calorie foods or calories to enter directly into the small intestine, and that can produce this dumping syndrome. And if anybody's had a severe episode of low blood sugar, it's very similar to that. It can lead to vomiting, nausea, weakness, sweating, faintness, and diarrhea. Now people say, well, why would you want to have that? And I say, exactly, because it makes you feel very poorly. But people learn that you can't cheat, or when you try to eat the wrong things, if you go out and you want to drink a milkshake, or you want a regular Mountain Dew or something, and it goes directly into your small intestine, it makes you feel like that, you're going to avoid those types of food. So it's a safety mechanism to prevent cheating. That's the only one you have it in, is the gastric bypass. You do have to take supplements, and the supplements include a multivitamin, calcium with vitamin D, vitamin B12, iron, and protein. For all these, I recommend that people take additional protein. As I said earlier, your body can't manufacture protein, and it needs it for healthy function. The risks of bariatric surgery, I went over those earlier. It's the same things as the previous slide. The risk of any abdominal surgery, bleeding, infection, anesthesia. It can lead to shoulder pain if you have problems underneath the left hemidiaphragm, pneumonia, complications of anesthesia, deep vein thrombosis, pulmonary embolism, and even death. When they started doing the stomach stapling procedure back in the early 70s, the mortality or rate of death was between 5 and 10%. These days it's between 0.5% and 1%. People still can die. We have not had anyone die or really had any major complications here in Greenville, but problems can occur. In looking at the hospitalization recovery, it's a very commonly asked question. Going through each procedure with the gastric band, we were doing many of these procedures as an outpatient. So you'd come into the hospital, you'd have your band placed, and we'd send you home between 4 and 8 hours after surgery. Now some of the insurance companies are mandating that we keep you overnight, but usually it's 23-hour or less in the hospital. Every one of our bands have been done laparoscopically. The return to work is 1 to 3 weeks. If you're sitting behind a desk working on a computer, you may be able to go back in 1 or 2 weeks. If you're outside and doing manual labor, then it may be longer. If we do have to do any of the open procedures, then it's usually 4 to 6 weeks. Return to normal activity, I let my patients go back to the gym or do any activity that they want at 3 weeks with a laparoscopic procedure. With the sleeve, it's anywhere from a 1 to 2 night stay in the hospital. We do most of our weight loss procedures on Mondays, and usually by Wednesdays at noon, the patients are on their way home. All of our sleeves have been done laparoscopically, and return to work is individualized 1 to 3 weeks. The Roux-en-Y is a 2-night stay. It's a laparoscopic approach in 95%, return to work in 1 to 3 weeks, and return to normal activities, same as the other procedures. With the sleeve and the Roux-en-Y gastric bypass, we do a swallowing study the next day to determine if there's any leak or obstruction or any problems with your anatomy that we may have changed. That's a simple test where you go down to the radiology department, you stand in front of an x-ray plate, and as you're drinking this contrast material, we follow it as it goes through your esophagus and then through the rerouted anatomy. In summary, looking at if you're a candidate for weight loss surgery, most of our patients have a BMI of greater than 40, but we do operate on people with a BMI of 35 to 40 if you have comorbid conditions. There is a new category for people who wish to pay for it with a BMI of greater than 30. It's only for the lap band. Hopefully in the near future, insurance companies will come around and see that you can improve people's health and improve their overall lifestyle with weight loss. The age is 18 to 65. 18 is firm. I don't operate on any, or neither does Dr. Chowdhury, anyone younger than 18 years of age. And the 65 is flexible, depending on the health status. You have to ask yourself whether you're healthy enough to undergo a major operation. You have to failed attempts at medical weight loss. We don't do these procedures if you continue to smoke cigarettes. If you have active drug or alcohol problems, you're also not a candidate. In my experience of doing these for 14 years, some of the worst problems I've had are people who continue to smoke cigarettes. It leads to decreased blood flow in certain areas of the intestinal tract, which can lead to strictures or narrowing or ulcerations. So if you want to continue to smoke, we're going to have to exclude you. You have to be cancer-free. If you've had breast cancer or leukemia and it's been treated and you're in remission, you're certainly a candidate, but any active cancer has to be treated first. No uncontrolled psychological conditions. You need a consensus from our multidisciplinary team. We get input on every patient from the psychologist, because everyone has a psychological evaluation. We get input from our dietitian. You have interaction with Jessica and from Carla, and then from the surgeon. So there's 5 of us who all have a say. You have to understand the surgery and the risks. You have to be committed to following our office protocol. That may sound rather pompous, but the people who do the best are the ones who follow our program. Our program is based in part on experience and based in part on what are getting the best national results. And people who want to be cowboys and go off on their own, they're the ones who oftentimes fail. And the most important is you have to be dedicated to a lifetime of lifestyle changes and to follow up with us. We want to see you for the rest of your life to make sure that you stay on the correct path. We've had a couple people who have, for one reason or another, either moved to different areas, and we've had a couple of them move back. We've brought them back into our program, and if you come in every 3 to 6 months to see us, meet with the dietitian, see Carla, see the psychologist if need be, talk to us. We try to make sure that you stay on that path towards weight loss and good health. Choosing the procedure that's right for you. Everybody has different considerations, their age, their health risks, the amount of weight you want to lose, the lifestyle and your eating behaviors. We kind of put all this together. A lot of patients will come in with a preconceived notion of what procedure they want to have done. If, based on our experience or other factors, we see something that might not make it a good fit or have good success, and we may try to convince you of a different procedure. If you don't have a procedure that you're considering, we will certainly make a recommendation. It has to be a mutual decision between the patient and the surgeon. We both have to feel comfortable with the decision of what procedure to go forward with. You have to discuss this, and we ask for your input from family and friends. Surgery can help change your life. It does improve or resolve those illnesses, those comorbid conditions which we mentioned. It does decrease your mortality risk, and it reduces the healthcare utilization and direct healthcare costs. We call it a tool. If you use that tool correctly, you can lose weight, improve your health, improve your overall quality of life. So I'm going to stop at this point, and I'm going to turn it over to Jessica Allen. She's going to proceed at that point. But I will be happy to answer any questions before I step aside. I recommend that you take a multivitamin whether you have weight loss surgery or you don't. I take one myself. I recommend it for all my patients, but with a sleeve or a band, I say just take a regular multivitamin because we haven't changed the pathways of absorption, and you don't need to take special vitamins like you do with a bypass. So I do recommend that you take a multivitamin with a sleeve and a band, but it's not as imperative as it is with the bypass. No, ma'am, it will atrophy. I mean, it'll shrink down, but it'll still be there. I mean, it makes things like hydrochloric acid and vasointestinal peptide and pepsin, and you know, even though it doesn't have food passing through it, those secretions will go down the pathway, and where they join that common channel, they will aid in digestion. But it does shrink down. Your body will regulate it. It's very hard to get down to your ideal body weight. I mean, we showed a few examples of that. We're not going to show patients who didn't have good results, but oftentimes people will lose 75, 80% of their excess body weight, and then it stops. It's very hard to get down to your ideal body weight. There's a small percentage of people who do. Should you go below that, we've had one patient who has, and for some reason she's just continued to lose weight. We slowly introduce carbohydrates back into the diet, and there's some little tricks that we have that we can get you back up if need be. Thank goodness it's a problem we rarely see.
Would you, if they had a lap band, would you just adjust the lap band then to allow them?
Well, we could certainly take fluid out of the band. That's the easiest one. We've had some women who have had a band placed, had good weight loss success, then they've gotten pregnant, and they've decided, well, while I don't want to have any nutritional problems, I want to have a healthy child, let's just take all the fluid out. So I've gone in, taken all the fluid out after they've delivered, and they feel comfortable. I've put the fluid back in, and it's been a good solution. The amount of excess skin that you may develop usually depends on the age. The younger that you are, the more elastic and the more rebound that the skin will have. The amount of weight that you lose, if you're going to lose 75 pounds or somebody's going to lose 200, who's going to have more excess skin? The person who loses. So the greater the amount of skin that you lose, the more likely it is to be loose. The older that you are, the more likely it is to be loose. And then certain people have different skin types. I'm not an expert in it, but some of the plastic surgeons that I know can look and say, well, that person's going to have problems. What can be done are, cosmetic type procedures. I think the more, exercise that you do, it's not going to tone your skin up, but it will tone the underlying musculature and oftentimes make skin a little bit healthier. The more activity that you have, the more your circulation is flowing. But a lot of people do, and they usually choose to have some sort of cosmetic surgery procedure. The gastric bypass doesn't allow you to eat a lot of carbohydrates. The sleeve doesn't either, for different mechanisms, but the more carbohydrates that you take in after any of these procedures, the less weight loss you're going to achieve. But it's in answer to your question, you're not going to be able to take in large amounts of anything. So whether it's carbohydrates, proteins, or fats, you're not going to be able to take in large amounts. We ask that you not get pregnant for a year after either of those procedures. We have had people who've had accidents or mistakes and gotten pregnant, and we haven't had anybody with birth defects or problems. But while you're in that rapid period of weight loss and your nutrition status is kind of fluctuating, We don't want to have, you know, a period where, say, you might have a few days where you don't get enough folic acid because you're nauseous, either from the pregnancy or from the bypass, and you know, you get a neural tube defect or something else. So we ask that you not get pregnant for a year after a sleeve or a gastric bypass or even a band. And if you want to get pregnant with the band in, then we'll just take the fluid out and let you eat what you want, and then after you've delivered, then we'll fill it back up. After a period of time, after 3 to 6 weeks, you're not going to tear or open up anything. If you're not going to have a leak or something immediately, you're not going to have a problem with the staple lines, because your body will actually grow right over them, and it fuses the tissue. So that's not going to be something that's going to occur. It's another good question is, can you stretch all these things? Certainly. Over a period of years with you know, overeating, that's why I say the most important thing is for you to commit to lifestyle changes, and the people who do that, you know, restrict how much they take in, get used to it, combine it with exercise or activity. Those are the people who are going to be the most successful. And you have to commit to life. None of these things is a panacea. You know, 5 to 10 years from now, you want to go out and just eat junk foods and things, you're gonna eventually gain the weight back. What this does is it allows you to lose the weight, make the lifestyle changes that are necessary, and then follow that path. That's why I said it's so important that you keep following up in our office and with our staff, so that we can just try to keep everything down that same pathway. But if it erodes into the stomach, then you have to have it taken out. If it slips, then what we do is we release all the fluid, we give you a period of a month or two, and then hopefully everything will migrate back to where it was, and then we try to refill it. If it doesn't work, then we have to go in surgically and reposition the band. If the balloon pops, then it's just a $2,500 piece of junk in you, and it will have to be taken out, or if you choose to leave it in, but it's not going to be functional. Knock on wood, we haven't had any balloons pop. They're pretty strong. I'm you know, about 225 pounds, and when I was at the training course, they asked us to step on the balloon and then jump up and down once, and I couldn't pop it. So it's pretty hardy. The main thing is you're going to feel tired. You know, we start you on a 2-week diet beforehand, and if anyone's, you know, been on a diet, you know, you kind of get worn down as your body gets, your metabolism slows down, you feel tired. Then the stress of surgery, both the stress of worrying about it beforehand, then the stress on your body of the surgery. So you combine all those factors together. After surgery, most people just don't have energy. They don't have the, ugh, I'm just so tired. You know, I can get out of bed and walk and do a few activities, but you know, going and putting in an 8-hour day, they just don't have the stamina. And that's why we ask you to get out of bed the night of surgery, start walking, start doing activity, because the more activity that you do, it seems paradoxical, but the more activity that you do, the more your stamina is going to improve and the more energy you're going to have. But it's primarily because of lack of energy, tired, that people don't go back to work sooner. Different insurance companies they have different requirements. I mean, everybody's policy in this room is probably a little bit different unless you work for the exact same company and do the same job. But everyone is different. What I'll do is I'll direct those questions to Jessica. Anyone else? Well, I'd like to thank you all for your attention, and I will turn it over to Jessica. She's going to go over the packet, and hopefully we will see some of you in the near future.
This is one of the most important sheets in your packet. I like to call this your roadmap to surgery, because it's got all the information that you need to complete to get to surgery, okay? The very first step in the gray box is you attend an information seminar. Y'all can mark that off because you've done it. Check. On to the next thing. The next thing in the green box, it talks about your medical records. If I contact you next week and you do have coverage for bariatric surgery, that doesn't mean that we can go to surgery tomorrow, unfortunately. That means that they do cover it if we prove it's medically necessary for you to have surgery. And how we prove medical necessity is through medical records. Most insurance companies require at least 3 years of medical records. Some require 5. So I typically ask for anyone that is going to go through with surgery to get me 5 years of medical history. I want records from your family doctor. I want records from your cardiologist, your pulmonologist. Ladies, OBGYN, they make us get on that darn scale every time we go. So there's records out there. Make sure you get those for me. I need them to, number one, prove that obesity has been a problem for several years, and number two, to prove any comorbid conditions that you have related to your weight, and that surgery is the last option for you, okay? It's medical records. When you find out if you're covered or not, you start requesting those medical records. Have them sent directly to me. In your packet, on the very front, on the pocket on the left-hand side is my card. It's got my name, it's got my direct phone number, my email, my fax number. Hold on to that, because we're a general surgery office as well, and we get lots of medical records. And if my name's not on them, it might not make it to my desk. Make sure you put my name and or attention Jessica Allen on those records if they're faxed, okay? So I let you know it's covered. You get your medical records, you make your appointments with a dietitian and psychologist. That's the yellow box. Their phone numbers are right there, so hold on to this sheet, okay? You're going to get your medical records, you're going to make those 2 appointments, and you're going to let me know when those appointments are, because I like to keep track of where you are in the process. Once you've got those 2 appointments completed, once I have your medical records and I've reviewed them to make sure that we've got plenty to prove medical necessity, then we make your doctor's appointment. You come in and see the doctor, and then after you see the doctor, you see me, and we pick a surgery date. Typically, surgery date is 2 to 3 weeks after seeing the physician. We do that for 2 reasons. One is because you have your pre-op diet of 2 weeks, so that gives you enough time to get that started and completed. The other is we do not send your medical records to the insurance company until after that visit, because every insurance company requires an evaluation from the bariatric surgeon, and we don't have that until you see them. So I have to wait for you to see them before I can submit your records, okay? So we submit your records, and it usually takes about 1.5 weeks to 2 weeks to get the final decision back from insurance if they're going to approve surgery for you or not. So that's why we wait. After surgery, you come see us a whole bunch for the rest of your life, and we're there to support you, and that's pretty much it.